Yeah, a very good noon to everyone. And at the outset, thank you, the organizers of DRS, Dr. Manoj Chawla, Dr. Purvi Chawla, and Bayer for having me today on speak on this topic of START AM, which is a real world data in patients with newly diagnosed diabetes using acarbose and metformin. Now, when so many molecules have been in focus with SGLT2 inhibitors, DPP4 inhibitors, GLP1 inhibitors, let's shift the spotlight a little bit to acarbose, a time-tested molecule which has been with us for some time now. Maybe we have forgotten a little about it. Let's renew our knowledge on it. So this is my disclaimer, and today what we are going to be discussing is why do we need combination therapy? What is the need of combination therapy in our newly diagnosed diabetic patients? The lesser known facts about acarbose and metformin, and we'll talk about the START AM trial, which was a first prospective study with acarbose metformin efficacy in our newly diagnosed type 2 diabetic patients. So this is not new to us that postprandial hyperglycemia has a significant role to play. More so in our population, it has been seen with the START study also that across India, be it any part of India, north, south, west, east, everywhere carbohydrate intake is very huge. You talk about the breakfast, lunch, dinner, everywhere, even the mid-meal snacks would also include some amount of carbohydrate. So it's not that in our population postprandial hyperglycemia is only seen when the lower A1C, but it is across the A1C spectrum, both the lower A1Cs or the higher A1Cs. Postprandial hyperglycemia has a huge role to play, and we as Asian type 2 diabetic patients have an insulin secretion deficiency, especially in the early phase. So when we talk about the newly diagnosed Indian diabetic patients with type 2 diabetes, there is a huge glycemic burden. Most of the patients are diagnosed, and which you all will agree will have a higher A1C of say more than 7 to 7.5, where postprandial hyperglycemia has a significant contribution in causing this A1C to go higher. So combination therapy, early initiation of combination therapy would lead to a better glycemic control instead of using a stepwise therapy or starting with a monotherapy. Currently, it is estimated that around 50% of our diabetic patients in India are utilizing combination therapies, and even the guidelines say so that if you feel that in the initial part of the treatment also you feel that a patient is eligible for a combination therapy, do go around with that. And this, again, the confidence came with the very significant verified trial where they used vildagliptin and metformin combination in patients who were drug naive and had A1C between 6.5 to 7.5. And there they saw that the glycemic control was not only significantly better, but also consistently seen over a period of time. And that led to the thought of using this combination therapy of acarbose and metformin. Even the IDF guidelines, if you see the evidence statement, they say that targeting both fasting and PP. The new the pathology nowadays, they recommend fasting and HbA1c, and they say nahi ho jayega, PPBS karne ka zarurat nahi hai. That's absolutely wrong. PPBS has a significant role to play. So whenever your patient is coming to your chamber and doing only a fasting and A1C, insist that they show you the PP report so that you know how to tackle that increase in blood sugar too. The baseline A1C threshold when we start a combination therapy can be between 7.5 to 9, but you can start with lesser A1Cs too. And when we prescribe two molecules, they should have complementary actions and to bring down the side effects. So if we talk about acarbose and metformin, maybe the metformin will take care of your fasting blood sugar, and the AGI like acarbose will take care of the postprandial peaks, and that would give a better comprehensive control. So when we talk about considering a combination therapy, we need to be addressing the high carbohydrate intake, the high cardiovascular risk which follows with the postprandial peaks, the enhanced insulin sparing and beta cell protection, You have to look at lowering the risk of hypoglycemia and body weight with a better tolerability and a safety profile. So when we look at these individual molecules with acarbose and metformin, and they kind of tick all the boxes. They give you a good glycemic control, they have an insulin sparing effect, incretin effect, lesser risk of weight gain and hypoglycemia, offers cardiovascular benefits, time-tested molecules, and beneficial effect on lipid lowering. So they are complementing each other as partners, and they can provide a good option for our patients with type 2 diabetes. Also, a lot of data has been seen that acarbose, if used as a second line OHA, it helps in bringing down the risk of atherosclerotic cardiovascular events, especially in our population. Now, is there any data gap when we talk about acarbose and metformin, FDC? What we know about is a GLOBE trial which was published in 2015, where they said that using acarbose metformin can help in reducing your fasting, postprandial and A1C. But what we don't know is the effectiveness and tolerability of this FDC in newly diagnosed type 2 diabetic patient as initial therapy. So the drug utilization patterns of acarbose and metformin in routine clinical practice in different care settings across various clinics were tried to look into. And there is when they address this, and the START AM trial was conducted in newly diagnosed newly diagnosed type 2 diabetic patients who were drug naive across India. So this was a study design. It was a prospective open label observational study, non-interventional single arm multi-center study, where they recruited newly diagnosed type 2 diabetic patient with hyperglycemia. So around 1728 patients were screened and 1714 patients were enrolled, and they were studied for a duration of 6 months, and what primary endpoint they were looking at was a mean change in A1C from baseline to 6 months, and the secondary endpoint they looked at was the A1C change from baseline at week 12, the changes in fasting blood glucose at week 6, week 12 and week 24, again the change in postprandial blood glucose, similarly the occurrence and severity of adverse events and hypoglycemic events, any change in the lipid profile, and any change in the mean body weight at week 12 and 24. Now this was a study setting. It was basically an outpatient clinic setting, a study which was done. The prescribing protocol was that the patients who were enrolled in the study were, the decision to start this combination was depending on the treating physician. They started with either one tablet of 25 by 500 or 50 milligram of acarbose and 500 milligram of metformin, and step-by increase depending on the need of the patient. The maximum tolerability of the dose was looked into and given accordingly, and patients were started on low dose and gradually increased to a higher dose. These were the inclusion and exclusion criteria. So newly diagnosed type 2 diabetic patient with an A1C of between 7.5 to 9 were enrolled. No contraindications of acarbose or metformin on local prescribing information, and the patient was not participating in any other investigation trial. These were the exclusion criteria. Patients receiving any other diabetic treatment were not included. With patients with type 1 diabetes with A1C of 9% or more than 9% were not included. With any serious infection, anyone who was pregnant or breastfeeding were not included. This patient disposition was 1731 patients were screened, and patients enrolled was 1714, and study completed in around 1589 patients. If you look at the demographic and basic characteristics, 20% of the total patients were of 40 years of age or less. The patients had various comorbidities along with diabetes, most common being hypertension and dyslipidemia. These were the baseline parameters. If you look at the A1C, the baseline was around 8. Other concomitant medications with the patient were on antihypertensives, vitamins, thyroid medicines, or proton pump inhibitors. Now the primary outcome what they seen was that there was 1% reduction in A1C over 6 months duration. So the mean A1C, they started with 8, it came down to 7.06, which was significant. So this reflects the effectiveness of this combination in effectively improving the glycemic control. Even when you look at the reduction in the A1C over a period of time, it started as early as 6 weeks and it was progressively declining at 12 weeks and 24 weeks. So by 56% of the patients achieved the target A1C of less than 7%. Even if we look at the fasting and postprandial blood glucose, there was significant reduction in the postprandial blood glucose by 56 milligram per deciliter. And if fasting sugar, if you look at it, was coming up, it consistently started reducing as early as by 6 weeks and significantly came down by 32 milligram per deciliter from baseline to week 24. If you look at the other outcomes, there was reduction in weight gain of around reduction in weight by around 2 kgs, and there was improvement in the lipid profile in the LDL, VLDL, and total cholesterol from baseline to week 24. So it was effective in reducing the lipid levels, particularly the atherogenic lipids, thereby potentially contributing to in reducing the CV risk.
Madam, you'll have to wind up.
Yes, in a minute, sir. The START AM trial showed that the mean dose of a carbose they could prescribe was around 72 milligram plus or minus 32.7. And the secondary outcome, what we were worried about the GI outcomes, but it could be tackled with symptomatic treatment, and it was overall well tolerated. And there was no fatality, very minimal risk of hypoglycemia and weight gain. So this is just summarizing the study which I just spoke about and concluding acarbose metformin FTC provides early, consistent, durable glycemic control along with good body weight reduction and betterment in lipid profile. Acarbose metformin combination FDC is well tolerated in newly diagnosed type 2 diabetic patient and then thus can be preferred choice as a first line combination in these patients. So I hope in the last 10 minutes I am able to convince that this can be considered as a first line option in our patients with type 2 diabetes who are drug naive. Thank you all for your patient hearing.